My name is Richard Chye. I'm the head of palliative care here at Sacred Heart at St Vincent's Hospital in Sydney. I'm a palliative care physician, and what that means is that I look after patients whose illness is not going to be cured, but I help them live as well as they can do before the end comes. So I've been doing this for almost 30 years, and I've looked after many patients and made their journeys as comfortable as possible. I think that two doctors looking after a patient or assessing a patient for VAD who doesn't understand the disease of the patient that the patient has, that worries me a lot. I think the first thing is that medicine is changing very quickly and that there's always new treatments available, new treatments that are emerging that can make a difference. I remember a gentleman who had lung cancer. This was quite a few years ago, 5-7 years ago, when new treatments were just emerging to treat lung cancer. And he was sent to me for palliative care. And I looked at his history, I talked to him, I went through all his tests, and it came to me that there was one particular test that was not done. So I ordered it, and it came back positive. It came back positive for that new treatment to be able to be given. And then he survived 4 or 5 years because he was provided with that treatment that made his cancer melt away. It wasn't going to cure him, but it made his cancer melt away, and he was given an extra 4 or 5 years. And as I developed the relationship with him, because that tablet eventually would not work at some stage, then he went on to chemotherapy. He was fearful of chemotherapy, fearful of the side effects of chemotherapy. But because I had a relationship with him and I could say to him, I'm going to look after you whilst you are having your chemotherapy. I'm going to look after you if the chemotherapy causes nausea and vomiting. And yes, he underwent chemotherapy and got another year or 2 out of it. His disease eventually caught up with him and he passed away very peacefully. I think he would certainly be a candidate for voluntary assisted dying. And I think he would have accepted that. But because I was able to have a relationship with him, because I said I would look after him, that changed his mind. I think that it made an incredible difference to his life. One is that he could enjoy life for a period of time. He could also spend time with his family, much more meaningful time with his family, get his affairs into order. I think the first thing is that medicine is changing very quickly and that there's always new treatments available, new treatments that are emerging that can make a difference. And if these doctors don't know what new treatments are available, then I fear that these patients will miss out. We use different medicines for depression. I have to know lots of different ways to use lots of medicines so that I choose the right medicines for the right condition, for the right patient. My fear is that legislation in New South Wales has to apply in Sydney, and it has to equally apply to the most remote area of New South Wales. And unfortunately, the availability of palliative care is dependent on your postcode. Yes, I run a service in Eastern Sydney, but there are lots of other areas in New South Wales where patients do not get access to palliative care. They're not getting access to the symptom management. They're not getting access to treatments that can alleviate the suffering because services are not there. And if the doctors and nurses who may be working very hard in remote New South Wales, they may not actually have the right expertise to relieve suffering. We need to make sure, first and foremost, that palliative care is available, good, high quality palliative care services and expertise is available to every resident in New South Wales. We need to get that right first. And my fear is for them, for those around them, for the doctors, nurses around them, they think therefore the answer is voluntary assisted dying. A lot of patients who come to me, to come to our services, will express in some form of words that they've had enough, that people may misconstrue as wanting voluntary assisted dying. And yes, some patients, a few patients, will say, I want euthanasia, and I know I have an illness that cannot be cured anymore, and therefore I want to be kept comfortable. The proponents of these legislation suggest they can access the legislation for voluntary assisted dying as well. But that's not what these patients want. These patients want to be looked after. Why do patients, when they ask for euthanasia, what are they actually asking for? 1 in 20, that's 5% of my patients will ask. And what we do in palliative care is to explore why that request has been put forward. And very often it is because they fear dying. Very often it's because they fear pain. They fear not being looked after. They fear being a burden on their loved ones. And when palliative care services, myself and my colleagues, my nurses, allied health, physiotherapists, social workers, when all of us get together and deal with those fears, then a lot of that ongoing request for euthanasia actually goes away.